Welcome to the workshop, Maintenance Therapy After Transplant, Multiple Myeloma. My name is Michaela O'Brien, and I will be your moderator for this workshop. It is my pleasure to introduce our speaker, Dr. Dan Vogl. Dr. Vogl is an Associate Professor of Medicine in the Division of Hematology and Oncology at the Abramson Cancer Center of the University of Pennsylvania. He is also the Medical Director of the Abramson Cancer Center's Clinical Research Unit. Dr. Vogel's research focuses on early phase clinical trials of novel therapies for relapsed and refractory multiple myeloma. Please join me in welcoming Dr. Vogl.
Thank you so much for that wonderful introduction, and it's a pleasure to be with all of you here today, here virtually. What we're going to be talking about today is maintenance therapy after transplant for multiple myeloma. I have a lot of information to share with you, but the overall learning objectives that I'll try to cover are why maintenance therapy is needed, which maintenance therapies we use and for how long, the length of disease control that we can expect, as well as the potential side effects from maintenance therapies, and then what therapies are available when myeloma progresses after maintenance therapy. So first, let's start off with what we're talking about and what we're not talking about in today's presentation. We're talking about multiple myeloma, and so that's one specific bone marrow cancer. So we're not going to be talking about other conditions that could also be treated with an autologous stem cell transplant like leukemia, lymphoma, amyloidosis, or smoldering myeloma, which is a earlier precursor form of the disease. We're talking about an autologous stem cell transplant because that's the main kind of stem cell transplant that's done for multiple myeloma, whereas allogeneic or donor stem cell transplants are much more rare. We're talking about transplant in general as part of treatment for newly diagnosed multiple myeloma. Although we do sometimes consider transplants, as I'll discuss, as treatment for relapsed or refractory myeloma. That's not the main way that we do transplant, so it's not the main area that we have information about maintenance therapy. And then specifically, we're going to be talking about maintenance therapy, whereas there's another type of post-transplant therapy called consolidation therapy that's set up a little bit differently and about which we have less information. So I'm really going to be concentrating on what we would call maintenance therapy. So first, let's start with myeloma in general to set the scene. Myeloma is a cancer of plasma cells. Plasma cells are usually the normal cells in the bone marrow that make antibodies to fight off infections. And myeloma happens when one of those cells develops an error in its instructions and starts making copies of itself, which tend to spread out through the bone marrow. And because those cells are all copies of each other, instead of making lots of different antibodies, they all make the same useless antibody. And so we diagnose multiple myeloma by finding plasma cells in the bone marrow, and you can see a picture here of what plasma cells look like in the bone marrow. And we can do tests to identify that those cells are indeed copies of each other. And because they're all making the same useless antibody, we can usually find that abnormal antibody in the blood or the urine or both. We call the disease multiple myeloma when those plasma cells cause problems, and the typical problems that they cause are listed on the left-hand side of the screen as the CRAB, or sometimes CRABby criteria, with high calcium levels, kidney or renal injury, anemia, which is low red blood cells, and bone lesions, which we typically refer to as lytic bone lesions. And then the I that we sometimes include refers to the risk of infection. So these are the problems that people with myeloma face. And to deal with those problems, we have medicines that can lower calcium levels and reduce the risk of fracture. We can treat bone pain with radiation and pain medications. We can give red blood cell growth factors to help stimulate red blood cells to grow for the anemia. We have measures that we recommend to help protect the kidney, and we use vaccines to help prevent infection and more liberal use of antibiotics than other people would generally get to deal with those infections. And in 2023, we still think that although we have many effective treatments for myeloma, we don't have a cure. And so that the treatment course for myeloma is generally marked by periods of response followed by eventual progression. And you can see in this drawing here, we follow the myeloma over time by looking at the level of the abnormal antibody in the blood, the M protein in general. When that goes up, that means the myeloma is growing, and you can see in the orange line there the idea that as the M spike goes up, or the M protein goes up, you then start a treatment and get a response with the M protein going down. You then can see sometimes an extended period of response, which we would call either a response or a response plateau, or maybe even a remission. But at some point, the disease starts to grow again, you apply another therapy, and get another response. And you can actually continue that cycle many times. But the challenge with myeloma is that over time, the chance of response tends to get lower and the duration of the response tends to get shorter. So that what we're trying to avoid is the situation on the right side of the diagram, which we call refractory relapse, where the responses are very short and the myeloma grows very aggressively and may not respond at all to the next therapy. So we do have a lot of treatments available to get these responses after responses. We use steroid medicines, especially dexamethasone, drugs called IMiDs, or immunomodulatory drugs. Thalidomide was the original one, but now mostly lenalidomide and pomalidomide. Proteasome inhibitors, bortezomib, carfilzomib, or ixazomib. We have monoclonal antibodies. Daratumumab is most commonly used, but isatuximab and elotuzumab are also used. Older chemotherapy medicines, which we often call cytotoxic chemotherapy agents, cyclophosphamide and melphalan are most commonly used, doxorubicin, and there are a few others that we sometimes use in combinations. There are a couple of newer agents that don't really necessarily, I guess they're each in their own category, Selinexor and venetoclax, and most recently immune therapies, either CAR T cells or a bispecific T cell engager called teclistamab, are really changing again the face of how we can treat myeloma. Every single one of these therapies can result in good responses, but still none of them currently appear to be curative. So because a lot of what we look for is treatments that lead to deeper and longer responses, about 40 years ago, people came up with the idea of doing autologous stem cell transplants for myeloma. And the real idea behind an autologous transplant for myeloma is actually a relatively simple one, that if a standard dose of chemotherapy is a good idea, then a higher dose is a better idea. That may not be the most brilliant concept in the world, but it happens, especially for myeloma and for our older chemotherapy drugs, to be true. So that as you increase the dose of the chemotherapy, it's better and better at bashing the myeloma down to a very low level. With the flip side being that it also hurts more and more the normal cells in the bone marrow that make our normal blood cells. And as you can see in the cartoon that I've made here, when you give that high dose of chemotherapy, which is really the treatment that kills the myeloma cells, the normal thing that would happen would be that the red blood cells, or the blood counts in general, would follow the course of that red line. And you would get low blood counts that would last probably for many months, and no one would be able to survive that. So the idea behind the autologous transplant is that if you remove some bone marrow cells from the body before giving the chemotherapy, put them in the freezer to protect them, and then after the chemotherapy has passed out of the body, and in the dotted green line, you can see that when you give the stem cells back, that dashed green line then represents what happens to the blood counts, which is that after a relatively short period of time, they reestablish normal ability to make blood cells, and the blood counts come back up much earlier than they would if you didn't do the autologous transplant. And so this is then a way of giving a very high dose of chemotherapy, and those of you who have gone through an autologous transplant know that comes with a whole bunch of other side effects, but reestablishing blood counts much more early, which allows it to be feasible to give that high dose of chemotherapy. Now, this treatment is part of our standard initial therapy for myeloma, primarily because we have a series of clinical trials that shows for sure that this intensive chemotherapy leads to longer responses, and then a fair amount of data that suggests that those longer responses also translate into patients overall living longer. But this very high dose of chemotherapy, although knocking the myeloma down to a very low level, sometimes for a very long time, is still not a cure. And so we've always been interested in the question of, should one do something after an autologous transplant for myeloma and give treatment to maintain that response? So when we talk about maintenance therapy, what do we really mean? This is my definition. I think it's additional therapy, additional treatment given in the setting of a response that contributes to longer disease control, to maintain the response that you've already gotten from a previous treatment. So we can talk about maintenance therapy after standard dose therapies. Often we might just call that continued therapy, because a lot of times it's just continuing the same medicines that you were on to get your response. But after high dose chemotherapy and a stem cell transplant, we call it maintenance treatment or maintenance therapy, and it usually consists of additional therapy that started several months later after the transplant. So why do we use maintenance therapy? Well, there are a host of possible reasons, and a lot of my colleagues at various institutions have given lots of reasons that we would want to use maintenance therapy. We might want it to deepen the response after the transplant, or even eliminate what we would call minimal residual disease, which is the lowest level that we think we can detect of myeloma in the bone marrow. We might want to stimulate immune responses against the myeloma, and we might want to avoid the development of resistance mutations in the myeloma cells so that they don't have a chance to become more aggressive by keeping them suppressed. And then we definitely would want to prolong disease response. But in my mind, the real reason that we use maintenance therapy is because of clinical trials that show that not only does it prolong disease response and maybe do all of those other things, but it actually makes people live longer. And the reason that we need it to do that is because after a stem cell transplant, in general, the myeloma is in a good response. So it's not necessarily that easy to make it in a lower response. In general, the myeloma is not causing problems. And once people recover from the side effects of the transplant, they're usually feeling good. And the maintenance therapy is not going to make them feel better. So since it can't make you feel better, what we really want it to do is make you live longer. And luckily, we have treatments that do that as maintenance therapy. So the maintenance therapy that has the most proven benefit in myeloma is listed here on the left, which is lenalidomide, also known as by the brand name Revlimid. There are 4 randomized clinical trials that compared lenalidomide either to a placebo or, in one case, to no treatment. And those trials overall showed improved overall survival, meaning that the patients who were randomly assigned to get lenalidomide, on average, lived longer than the patients who were randomly assigned to get a placebo. And that was even though the patients who got placebo pills, when their myeloma grew, they generally had access to lenalidomide at the time of progression, which means that the trials were really comparing giving lenalidomide as maintenance after a transplant to saving it for later on and using it as treatment for relapsed disease. And it turns out that using it as maintenance after a transplant makes people live longer than saving it for later. And this improvement in overall survival was confirmed in what we call a meta-analysis that took the data from all of these trials and put them together and did a larger analysis and really did confirm that lenalidomide makes people live longer when given as maintenance therapy after transplant. Those are powerful data and make it really something that we would want to do. The other drug that does have some data is Bortezomib, also known by the brand name Velcade, which has 1 randomized clinical trial that did show improved overall survival. And the only thing that makes us a little iffier about it is that in that trial, the Bortezomib was given both before before the transplant and afterwards as part of maintenance. And so it's not completely clear whether it was the bortezomib given before or the maintenance therapy that really contributed to the overall improved survival. And so the data supporting using bortezomib in maintenance therapy are just not quite as strong as they are for the lenalidomide. There are some other maintenance therapies that have been tried in myeloma. Steroid medicines like prednisone or dexamethasone, thalidomide, which is an older version of lenalidomide, and ixazomib or Ninlaro, which is an oral proteasome inhibitor very similar to bortezomib or Velcade. All of these three medicines have all had clinical trials that showed limited or no benefit to their use in maintenance therapy. So in general, we do not use them. On the other hand, there are some situations where I or some of my colleagues will use other agents in maintenance therapy, either lenalidomide in combination with other drugs, I would say most commonly bortezomib or Velcade, or pomalidomide, which is a newer version of lenalidomide, either by itself or in combination. And we tend to use these in situations where we are more worried about patients. Their myeloma may have some features that place them at higher risk for early progression and resistance to therapy. But while it makes logical sense to use them in these situations, there are limited data that show that there's an actual benefit. So that we tend to consider using these, but they're not well proven, these combinations or alternative agents. For lenalidomide maintenance, the typical plan is to start 3 to 6 months or 90 to 100 days after a stem cell transplant, although sometimes we'll start as early as 60 days. The standard dosing that was used in clinical trials is to start with a dose of 10 milligrams once a day, considering after a few months of therapy, a dose increase to 15 milligrams. The idea here, I think, for the trials was that we were worried that some people might not tolerate the higher dose of 15 milligrams, so we wanted to start off more gently and then increase the dose for people for whom we could. We do know that a lot of people don't tolerate the 15 milligram dose and need to go back to 10 milligrams. So I'm not usually very aggressive about increasing that dose to 15 milligrams, but if people are feeling well after a few months, I generally will increase it. And there are two different dosing schedules that have been used in the clinical trials that showed the benefit of lenalidomide, either a 3 weeks on, 1 week off schedule, or a continuous schedule with no weeks off. And I think either of them can be used and considered to be standard. And then we generally plan to use dose adjustments for side effects, decreasing from 15 to 10 milligrams, or from 10 to 5 milligrams, or even 5 milligrams every other day. And I do tend to be fairly liberal with dose reductions for lenalidomide because that's what we did in the clinical trials. We reduced the doses when people had side effects and still saw that improvement in overall survival. And because we don't have any evidence that it's very important to stay at the full dose of lenalidomide during maintenance therapy. So what side effects do we see that lead to those dose reductions? Well, I think the most common ones are fatigue and diarrhea and low blood counts, especially low neutrophils, which are the white blood cells that help fight off infection. We do often see rashes, and sometimes they can be severe. Sometimes people will just have itching rather than a rash that you can see. All of these side effects are usually mild, but they can be severe, and they can make people miserable, and the low neutrophil count can increase the risk of infection. So for these, we do tend to decrease the dose when they get bad. We do sometimes see muscle cramps in patients on lenalidomide maintenance. Those can sometimes be mild, but sometimes can really make people miserable if they're very frequent. We also know that there's a risk of blood clots with lenalidomide, and so in general, we give people something to prevent blood clots, at minimum a daily aspirin, although sometimes we use other blood thinners. And a less common side effect, but still worth paying attention to, is neuropathy or nerve damage that can lead to numbness and tingling in the fingers and toes. That's much more common with bortezomib, or Velcade, but it can be seen with lenalidomide, especially when we use it for a long time as maintenance after a stem cell transplant. What's interesting is that some of these side effects will happen even though people didn't have them when they were using lenalidomide before the transplant, and sometimes more severe, even though before the stem cell transplant they were using lenalidomide at a higher dose of 25 milligrams. And we're not sure why that happens, but we definitely see sometimes different side effects during maintenance after the stem cell transplant than we did beforehand. One topic that's gotten a lot of attention is the risk of second cancers with lenalidomide maintenance, especially after a stem cell transplant. And the placebo-controlled trials that showed the benefit of lenalidomide maintenance, a couple of them did show a higher risk of malignancies with lenalidomide maintenance after a stem cell transplant. The biggest of the blood and bone marrow, with leukemia and a pre-leukemic condition called myelodysplastic syndrome, or MDS, being the most concerning. This is a real concern, although I'm not completely convinced that the trials correctly accounted for the fact that people on lenalidomide lived longer and also stayed on the study longer, which means we had more opportunity to see them develop a second cancer. More importantly, though, it's very clear that on these trials, the risk of the myeloma progressing was always higher than the risk of a second cancer, regardless of whether people were on lenalidomide or on placebo pills. And there's no evidence that the risk of serious harm or death from a second cancer would outweigh the benefit of lenalidomide in prolonging overall survival, making people live longer with myeloma. So that even though this risk is there, we think it's small compared to the benefit of getting lenalidomide, and in general, it does not stop us from recommending lenalidomide maintenance after a stem cell transplant. So how long do we continue? There's no good data on the optimal duration of maintenance therapy. The trials that looked at lenalidomide maintenance generally used a strategy of indefinite maintenance until progression. Concerns about second malignancies have led some experts, especially over in Europe, to recommend fixed duration therapy, meaning continue lenalidomide for 1 to 2 years and then plan to stop. I would say here in the United States, for most patients, we use a strategy of indefinite maintenance therapy, meaning that we plan to continue until the myeloma progresses or the lenalidomide causes intolerable side effects, or, and I think this is actually important, that the patient really wants to stop, because we don't have good data on the optimal duration of maintenance, which means that once you've gotten through a year or two of lenalidomide maintenance, if you ask the question, is there good evidence that I need to stay on the lenalidomide in order to get the benefit of living longer? The answer is no. There have not been any trials that looked at that question. And on the trials that we did do of lenalidomide maintenance, patients did have dose reductions and did end up stopping treatment, so that we know that the benefit of lenalidomide maintenance was in a group of patients where some people did end up stopping treatment, which means that we're not sure that after any period of time that it's essential to continue on lenalidomide or to maintain the same dose. So if the lenalidomide is causing side effects or it's just getting to be a real drag, I think it's reasonable to consider stopping after a period of time, given that we don't know for sure that continuing therapy would provide the same benefit. So how long do these responses last? Well, I think the average duration of response, or the median, meaning 50% of people, have their myeloma start to grow by about 4 years. I'm not sure that number is that useful, though, because it does hide a wide range. And while some people will have a disappointingly short duration of response, some people will have many years, 5, 10, 12 years of response from maintenance lenalidomide. And so I certainly would not think of there being any maximum duration of response from lenalidomide maintenance, and we always hope that our patients have a long response after transplant on maintenance therapy. For bortezomib maintenance, I think I have a lot less data because there are fewer trials, and so we use it less often. But similarly, we generally start therapy about 3 to 6 months out from a transplant. Bortezomib is given as an injection, usually as a subcutaneous under-the-skin injection because the IV route of administration has more side effects. And because this is how it was done in the clinical trial showing a benefit, we usually plan to give the bortezomib every 2 weeks. I would say we're more likely with bortezomib maintenance to do it for a shorter period of time because everybody tends to get tired of doing the under-the-skin injections, but it can be indefinite maintenance therapy until progression. And bortezomib tends to cause similar side effects to lenalidomide, fatigue and low blood counts, especially low levels of the platelet count, which helps the blood to clot, although rarely to the point of having a risk of bleeding. More specifically for bortezomib, we definitely want to watch out for the risk of neuropathy, the numbness and tingling in the fingers and toes, because that's more common and can be more severe and more permanent with bortezomib. And bortezomib increases the risk of reactivating the chickenpox virus as the painful rash known as shingles. So everyone on bortezomib should be on an anti-shingles antibiotic. Acyclovir is one of them, but there are others. So what do we do after maintenance therapy? When myeloma progresses after maintenance therapy, we have a variety of options. And so this drawing that I have shows in kind of cartoon version some of the drug or all of the drugs that I included early on in my list of agents that we use for myeloma. And I put it this way because we usually try to think about combining drugs from different classes together. So we're often using monoclonal antibodies, immunomodulatory drugs, and proteasome inhibitors together. And then we tend to combine them in some cases with cytotoxic medications, with steroids, with a medicine called venetoclax, with selinexor. And then we also have as options our newer immune therapies, the CAR T cells and the T cell engagers. And how to choose among all of these options and all of the various combinations is not particularly easy, but what's good is we do have a lot of options. And the general principles are that most people, especially for the first treatment after maintenance therapy, should get a combination therapy and usually a triplet, meaning usually 2 medications in combination with dexamethasone. Most commonly, we'll use the antibody daratumumab, or its almost identical drug, isatuximab. And so the daratumumab is the D in these combinations, and we have abbreviations for all of our other partner drugs, but in this case with lenalidomide or bortezomib or carfilzomib or pomalidomide. We often will combine immunomodulatory drugs like lenalidomide or pomalidomide with proteasome inhibitors like carfilzomib or bortezomib. And then I'm a big fan of cyclophosphamide combinations, usually in combination with bortezomib or carfilzomib. In later lines of therapy, we're often turning to elotuzumab, which is another of those monoclonal antibodies, usually in combination with lenalidomide or pomalidomide, sometimes considering selinexor, which has an X in the combinations because of its brand name Expovio, and can be combined with a variety of medications. And I think it's important, I like to keep in mind for my patients whose myeloma has this genetic translocation between the 11th and 14th chromosomes, that venetoclax, although it's not approved for myeloma, has been shown to be particularly effective in that subset of myeloma. In addition to these combination therapies, we sometimes think about doing a second stem cell transplant. And this is often a question that I get from my patients. They kind of assume that after their myeloma progresses on maintenance therapy after their first transplant, that automatically we would plan to do a second transplant. That approach actually has relatively limited data, so it's not usually at the top of our list for most patients. it's clear that the duration of a response to a second transplant is correlated with the duration of the response to the first transplant, but it's rarely longer than the response to the first transplant. So I'm thinking about doing a second transplant most often for my patients who have had a particularly long response to the first transplant. And usually patients whose first transplant, especially with lenalidomide maintenance, gave them longer than the average 4-year duration of response, because with all the side effects of a stem cell transplant, I'd want to make sure that we really were getting a lot of benefit for going through those side effects. The last two options that I'll mention very briefly in terms of therapy after a stem cell transplant, after maintenance therapy after a stem cell transplant, are these newer immune therapies. And we are very excited about it. This treatment called chimeric antigen receptor, or CAR T cells, involves genetic retargeting of immune T cells. It does require a T cell collection, and this whole process often looks to people a lot like a stem cell transplant, but ends up being both, I think, overall easier to go through and very different in how it works. But it does require a T cell collection, usually shorter than stem cell collection, some chemotherapy, although in general less than what you would expect to go through with a stem cell transplant, and then giving back to the patient T cells, their own T cells that have been genetically modified to put a targeting protein that targets the myeloma. And then those T cells, when they go in, have some specific risks of causing inflammation in the body that's known as cytokine release syndrome, and sometimes confusion that's called neurotoxicity. But when those T cells go in and start killing the myeloma cells, they can be very effective at doing so. There are two products currently approved, one known as Ida-cel, the other abbreviated as Cilta-cel, with the brand names of Abecma and Carvykti. Both of them target the same target on the surface of the myeloma cells, known as B-cell maturation antigen, or BCMA. And we can see very high response rates and sometimes very long-lasting responses with these CAR T cells. And then the other, very newest treatment option for relapsed myeloma is a drug known as a bispecific T-cell engager, which is essentially a double-headed antibody that, again, is a way of getting the immune T cells to attack the myeloma cell. One end latches onto the T cell and the other onto a target on the myeloma cell. The medicine that's been approved is called teclistamab, or has the brand name Tecvayli, and targets the same target on the myeloma cell as the CAR T cells, so is known, which is the target known as BCMA. The teclistamab has the advantage over the CAR T cells that it doesn't require any collection of cells or chemotherapy, but does require ongoing dosing every 1 to 2 weeks on an ongoing basis. So there's kind of a trade-off in the way that we get the T cells to attack the myeloma cells. So to conclude, through all of that information, I think it's really important that maintenance therapy after transplant for myeloma is based on clinical trials showing improvements in overall survival and making patients with myeloma live longer. The most common and the most proven maintenance therapy is lenalidomide or Revlimid given as a single agent. Side effects during maintenance therapy are typically mild, but often can lead to dose reductions and sometimes to discontinuation of maintenance therapy. And we do have many options available for treatment of myeloma that has progressed after maintenance therapy. And that's where I'll conclude and make sure that we move on to any questions that people have.
Thank you, Dr. Vogl, for this excellent presentation. We'll now begin the question and answer session. If you do have a question for Dr. Vogl, please use the chat box on the left side of the screen to submit your question. We'll try to answer as many questions today as possible. All right, our first question is bile salt diarrhea a result of taking the drug Revlimid? Is there a good alternative to Revlimid?
So I think it's great that that this question it refers to the diarrhea as bile salt diarrhea because it points out one of the things that we can do about the side effects from lenalidomide or Revlimid maintenance after transplant. And again, I do think that we have really good evidence that lenalidomide is a good medicine to use as maintenance therapy and limited evidence for other medications. But diarrhea from lenalidomide is a real problem and can make patients really miserable. And so one way to deal with it is to lower the dose of lenalidomide. Another way is to give medicines to try to treat the diarrhea. And we can use kind of standard antidiarrheal medicines. Imodium, which the generic name is loperamide, or Lomotil, are both antidiarrheal medicines, although both of those can result in a lot of constipation, which then often leaves patients flipping back and forth between diarrhea and constipation, which is also pretty miserable. But there is some evidence that giving medicines that bind up bile salts or bile acids that are produced by the liver and pushed out into the intestines as part of normally how our bodies work, that those bile salts can be very irritating to the intestines and are implicated in how lenalidomide causes diarrhea for patients. And these bile acid sequestering drugs are an old class of cholesterol-lowering medicines that were not very effective at lowering cholesterol, but actually are pretty good at binding up bile acids, and there's good evidence that they can improve the diarrhea from lenalidomide. The one that was most studied is a drug called colesevelam with the brand name Vogl, but there's another one called cholestyramine. And I've had pretty good experience using these medicines to control the diarrhea for patients on lenalidomide. And what's nice about them is that in general, they don't seem to cause constipation. And they can be very effective. So if you do have diarrhea from lenalidomide and you're really trying to avoid reducing the dose or stopping the medicine, then I think trying these older cholesterol-lowering medicines, which don't have any of the same side effects as our current effective cholesterol, the statin medications that we typically use for cholesterol treatment, these older bile acid sequestering drugs are actually pretty effective with pretty minimal side effects.
Can you discuss any long-term side effects there may be from the high dose of chemotherapy given before transplant?
That's a great question. In general, I think that the bargain of going through high-dose chemotherapy for myeloma is that you get a lot of short-term side effects, but not that much in the way of long-term side effects. But the long-term side effects from the high-dose melphalan chemotherapy can be a little bit hidden. And so, one of them that we do worry about is the risk of second cancers. It's pretty clear that melphalan chemotherapy is probably associated with an increased risk of second cancers. But then that kind of gets lumped in with the fact that patients with myeloma also, in general, even without a stem cell transplant, have a higher risk of second cancers. And we worry about the lenalidomide maintenance contributing to second cancer. So we never really know if someone does develop a second cancer, which thing caused that increased risk. And I know a lot of my patients do complain of a sense of mental fogginess. Some people will call it chemofog, that can persist for a long time, and we're never quite sure exactly which part of their treatment caused that problem. But we do think that it might be the high dose of chemotherapy. But in general, other than those things, we don't expect long-term side effects like diarrhea or low blood counts or nausea or neuropathy coming directly from the transplant medication itself.
Okay, what's the best myeloma maintenance therapies to achieve the maximum durable long-term remission?
So as I said in my talk, I think that question was entered even before I started my talk, so hopefully I answered it during my talk, which is really that I think the best evidence that we have is for lenalidomide by itself as a maintenance therapy. And there are other medications, and some of them have theoretical benefits beyond lenalidomide by itself, but I don't think they're nearly as proven. And so I think the standard answer for the vast majority of people should be lenalidomide.
If you receive a negative MRD test, is that an indicator that you can stop maintenance safely?
Boy, that is a tough question. An MRD test, or a test for minimal residual disease, in general is a bone marrow test that looks for a very, very low level of myeloma cells. And if you can't find even that very, very low level, then we call that MRD, or minimal residual disease negative. And we kind of see that as the deepest possible response that we can identify for patients. And there are definitely studies that show that if you get to an MRD negative response, your duration of response and overall survival are better than if you don't. But there aren't a lot of studies showing what to do with that information for an individual patient. So I've actually heard it both ways, so that I've heard experts say that if you get to the point where you are MRD negative, then your maintenance therapy is clearly working great and you should continue it. Whereas others have said if you get to that MRD negative response, then your myeloma is in such a good response that you don't need to continue on lenalidomide maintenance afterwards. There are trials that are starting up and kind of moving through right now that are hopefully going to answer these questions later on, where we're using MRD tests to assign patients to either continue or stop maintenance therapy. But I think we're several years away from even getting the preliminary results from those trials. So right now, from my perspective, we just don't know what to do with that MRD testing. And so if you've gotten an MRD test and are confused about what it means for you, I don't think that's your fault. I think it's that we're still learning what these tests mean and what we're going to do with them, which also means that I often don't do MRD testing for my patients in the post-transplant period because I'm just not sure how I'm going to use the information.
Can multiple myeloma, allotransplant, and maintenance drugs cause problems with the parathyroid gland?
That's an interesting question. I don't know of any direct effect of myeloma or either kind of transplant or maintenance therapy on the parathyroid glands. Our parathyroid glands are the ones that control the calcium level in the blood. And that said, it's fairly common, even in people without any of these other conditions, to develop disorders of the parathyroid gland, usually an overfunctioning parathyroid gland or hyperparathyroidism, which can elevate the calcium level, which in myeloma can be a little bit concerning because myeloma can also elevate the calcium level. So figuring that out is really important. But usually there are pretty good treatments for overactive parathyroid glands, and it's usually not a major problem for people. There is also, right next to the parathyroid gland, is the thyroid gland, which produces a hormone that overall controls the general metabolism in the body. And that can often become underfunctioning or hypothyroidism, which can make people feel very tired and worn out and slow down all sorts of processes and lead to changes in the skin and hair and nails and constipation from everything in the body slowing down from not having enough thyroid hormone. And I do think there's a chance that our myeloma treatments can affect the functioning of the thyroid gland, so that when my patients do have maintenance, do have fatigue after a stem cell transplant, during maintenance therapy, or even during other treatments for myeloma, I try very hard to make sure I do a blood test to look at their thyroid function, and if it's low, to give them some thyroid hormone pills, because that can really make people feel a lot better if the thyroid gland is underfunctioning. But that's different from the parathyroid gland, and so it's really important to make sure that you're paying attention to which one your doctor is talking about.
Can you discuss T cell exhaustion and its relationship to immunomodulators?
So T cell exhaustion is the concept that when immune T cells in the blood and throughout the body are trying to fight something off, either an infection or, in this case, a cancer, T cells are the cells that have the job of destroying other cells in the body when they develop errors inside them. But when they are constantly stimulated and trying to fight something off on an ongoing basis, there undergoes some signaling changes inside them and some changes in their instruction that indicate that they're kind of shutting down. And we refer to that as exhaustion. So they stop being active and stop being effective at killing the myeloma cells. There are some indications that some of our medicines, and that's particularly the drugs that we call immunomodulatory drugs, which is thalidomide, lenalidomide, and pomalidomide, that those medicines can stimulate T cells and may be able to overcome T cell exhaustion. And there are theories that maybe that's one of the reasons that lenalidomide works after a stem cell transplant during maintenance therapy at a time when we're not giving other medicines like steroids that can actually inhibit T cell function. And that maybe really lenalidomide is working by stimulating T cells and the immune cells when the myeloma is at a particularly low level, and that's why lenalidomide is particularly effective during maintenance therapy. So there are also ideas to use medicines in this class, like lenalidomide and pomalidomide, after our newer immunotherapies that depend on activating T cells, like the CAR T cells and like teclistamab, because it's possible that you could see some synergy between the immunomodulatory drugs and the T cell redirecting therapies, and that's an area of ongoing investigation.
Can a patient have CAR T cell therapy after a kidney transplant?
Oof, we're going a little bit far afield from the area of maintenance therapy after a stem cell transplant, but I think that is a good question, and I don't think we know the answer for sure. People who had prior kidney transplants were not included in any of the clinical trials of CAR T cells. And although you would think that giving a T cell that is specifically directed, genetically oriented against the myeloma cells shouldn't have any danger to a transplanted organ, we know that T cells are really important in the process of organ rejection. And when we give CAR T cells, we probably do give some other T cells along with the CAR T cells that are just regular activated T cells. And the CAR T cells can set off a lot of inflammation in the body and induce other T cells to become active, which means that I think we'd worry a little bit doing CAR T cells after a kidney transplant that we might see rejection of the transplanted kidney. And so I think it would require some very careful thought before doing something like that, and a real consideration of what the alternatives would be.
What treatment would you recommend for the rash? Specifically, they broke out with a rash on their chest area.
So rash is really common with lenalidomide maintenance after a stem cell transplant. There are a couple things that we can consider doing. The most common treatment that I recommend are anti-allergy medicines, the antihistamine drugs, especially loratadine, the brand name is Claritin, or cetirizine, which is Zyrtec, or fexofenadine, which is Allegra. Those ones, which I think of as almost interchangeable, although some people think one will cause more side effects than the other, Those can be very helpful with rash and with itching, usually if it's pretty mild. If itching is a problem at night, then the older antihistamine drugs like diphenhydramine or Benadryl can be more useful. Those tend to be a little bit sedating, so you don't generally want to use them during the day. And sometimes we'll use steroid creams like hydrocortisone for a rash from lenalidomide. But if the rash is pretty severe, then usually we want to at least temporarily stop the medicine, wait for the rash to subside, maybe give the antihistamine drugs and restart the Revlimid or the lenalidomide at a lower dose, so that we try to avoid really exacerbating the rash, because I have seen some patients get a really severe rash with lenalidomide. If the rash is more mild, then I think trying to manage it symptomatically with those treatments can be helpful. And then often with lenalidomide, what we see is just a lot of dry skin and maybe these tiny little red, dry, scaly spots kind of scattered over the arms and the chest. And I think those things can be helped by hydrating skin ointments. The most common ones that I use are over-the-counter Aquaphor or Eucerin or CeraVe, and those tend to not have any side effects, although they can feel a little goopy when you put them on, but can be very useful in helping with the dry, irritated skin if it's not really a full rash.
You talked a little bit about MRD earlier. What treatments are available for a patient who is MRD positive?
So, similar to what I said just before, I think we don't really know what to do with that test that says that you're still MRD positive, say in particular after an autologous stem cell transplant and on lenalidomide maintenance. So I have seen some experts say, well, if you're MRD positive, we should definitely continue the lenalidomide maintenance because you need it to keep the disease under control. And I've seen other people say, well, if you're still MRD positive, then it's not working well enough, and we should change treatments to try to knock the myeloma down even further to get it to be MRD positive. And they're making a logical leap that if people who are MRD positive don't have as long myeloma control as people who are MRD negative, then it's a good idea to change treatments and try to make people MRD negative to get them to that same point. But that strategy has not actually yet been evaluated in clinical trials. And I have seen patients go through a lot of different treatments trying to knock their myeloma down to being MRD negative when we don't know for sure that that's needed. So, in my practice, I don't do a lot of MRD testing, but if I did and my patient had a positive MRD test but was otherwise feeling well, their myeloma was at a very low level, there was no evidence of it growing, I would tend to just keep them on their ongoing maintenance therapy, considering that it was working. And I generally don't have a practice, although I know some of my colleagues do, of chasing MRD tests and trying to make the MRD test go to negative.
How can I tell if diarrhea, rash, muscle cramps, or spasms are actually being caused by Revlimid or other health issues?
That is a question that I often ponder with my patients. And in the end, I think there's really only one way to know for sure. You have to take a treatment holiday from the lenalidomide, from the Revlimid, and in my experience, you have to give it at least 2 months off treatment and see how much better you feel off treatment. And then if you feel a lot better, then maybe you want to try going back on the lenalidomide maintenance, maybe at a lower dose, and see if you get the same side effects again. And if you feel better off treatment and get the side effects back when you go back on the treatment, then you know for sure that it's related. But otherwise, it can be tough to tell if the fatigue is mild, if the diarrhea is just intermittent, if the rash comes and goes. It can be really hard to tell, is that really related to the lenalidomide or not, or is something else going on, or am I just not getting enough sleep and feeling stressed because of stuff going on at work. All these things can make it difficult to figure out exactly what's related. And I do, on a regular basis, set up treatment holidays where we kind of really try to figure out, going off and on and sometimes off again, to see what feels better when you're off the lenalidomide. And then you can make an educated choice, knowing how bad the side effects are on the treatment and how much better you feel off, as to whether the impact on your quality of life is to such a degree that it really makes sense to stop the treatment. Because, and I did see another question that someone had put in about quality of life. I agree that quality of life is really important. And so we do know that starting lenalidomide maintenance from clinical trials is associated with people overall living longer. But because we don't know what the optimal duration of that maintenance therapy is, if there's a significant impact on quality of life, I am very much in favor of dose reductions and, if need be, stopping the treatment completely.
Okay. We're running out of time, and this is going to have to be our last question. Does transplant eliminate chromosome deletions P53 and 1114? Do they get controlled in maintenance therapy?
So that's a good question. That has to do with the genetic errors that we often see in myeloma cells that can sometimes give us prognostic information about how people are going to do in the long run. Those two particular abnormalities individually generally have different prognostic implications. So the 17p deletion, which is where the p53 gene is in our chromosomes, is usually associated with a higher risk, a shorter duration of response, and earlier development of resistance to therapy. Whereas the 1114 translocation by itself is often associated with more indolent myeloma, shorter time to progression, longer time to progression, and a generally better prognosis. Although when seen together, it's usually the higher risk abnormality that seems to control how the myeloma behaves. Unfortunately, I don't think there's any clear evidence that any of our treatments specifically get rid of the cells that have those abnormalities or get rid of the abnormalities themselves. And so if you start myeloma with a 17p deletion, I think that 17p deletion tends to stay with the myeloma no matter what we do. However, some of our treatments, especially some of the newer immune therapies, can still provide really good responses, even if patients have these high-risk abnormalities, and maybe independent of whether the patients have these high-risk abnormalities. So that I do think there are effective therapies that we can bring to what genetic changes are present in the myeloma cells.
On behalf of BMT InfoNet and our partners, I'd like to thank Dr. Vogl. This presentation was very helpful. And thank you, the audience, for your excellent questions. Please contact BMT InfoNet if we can help you in any way, and enjoy the rest of the symposium.